Hello, my name is Dr. Adam Dalia. I'm a cardiothoracic anesthesiologist at the Mass General Hospital. Today I'm going to discuss management of intraoperative vasoplegia. I don't have any disclosures relevant to this talk. For objectives, we're going to discuss the definition and diagnosis of vasoplegia. We're going to discuss the prevalence of vasoplegia, proposed pathophysiology of vasoplegia, as well as rescue treatment options. And this will all be within the lens of intraoperative care, but also a little bit of perioperative care. So the immediate post-op, either in PACU or ICU, as well as preoperative, picking patients up from the ICU, managing this vasoplegia while transporting to the operating room and dealing with patients in vasoplegia. So how do we diagnose vasoplegia? There's not one singular definition available, but generally, if you look at the literature, most of the definitions begin with a MAP less than 60, with a cardiac index greater than 2.2, a systemic vascular resistance less than 800, and being on high-dose vasopressors, generally between 0.2 and 0.5 mics per kilo per minute of norepinephrine equivalents. So not just norepinephrine, but the norepinephrine equivalents of all of the pressors that you may be on. So phenylephrine, norepinephrine, epinephrine, and vasopressin all together. You also want to make sure you're ruling out other forms of shock, like cardiogenic shock, which is why the cardiac index should be greater than 2.2. If it's not greater than 2.2, you may be dealing with cardiogenic shock. But if you find yourself in a situation where you have all of these parameters, a MAP less than 60, an index greater than 2.2, and a low SVR on high-dose pressors, you may be dealing with vasoplegic shock or vasoplegia. And it also needs to be refractory to volume resuscitation. So what's the prevalence of vasoplegia? Well, in the cardiac surgery population, which is where we often hear about this, it's 8 to 20%. But in the general surgical population, it's still prevalent between 2 and 4%. And if you can imagine, even at 2% of surgical patients in a hospital doing about 20,000 operations a year, that could be almost 400 patients a year, or at least one patient a day. So although the percentage is low, you still may encounter this quite frequently. It's been described in all phases of perioperative care, pre-op, intra-op, and post-op. And the mortality, unfortunately, is very high, 25 to 50%. In more specific subsets of patients and cardiac surgical patients, the mortality is greater than 25%, maybe closer to the 50%, while in the general surgical population, it's closer to that 25%. High rates of renal failure, prolonged hospital stay, and even death with vasoplegia, unfortunately, is common. So how do we define vasoplegia, and what's the pathophysiology behind vasoplegia? Well, it's not well understood, but there are certain mechanisms that can occur that we have seen, and these mechanisms and understanding these mechanisms can then help dictate the treatment. So you have nitric oxide dysregulation, you have abnormal hydrogen sulfide metabolism, you got endothelial dysfunction occurring, you have an increase in prostaglandin release, a decrease in vasopressin, as well as ascorbic acid sequestration. And it's important to understand all of these components of vasoplegia because each treatment that we're going to be discussing attacks one part of this vasoplegia. What are specific patient risk factors for vasoplegia? Well, they have seen that patients that are older, that are male, may be at higher risk for vasoplegia. Having a high BMI, high body mass index, particularly sepsis, and more specifically infectious endocarditis, low ejection fractions, less than 35%, and then patients on mechanical circulatory support, such as ECMO, or even a durable mechanical support like an LVAD. Also blood transfusions, intraoperative blood transfusions and immediate preoperative blood transfusions have been associated and are considered risk factors for vasoplegia. What are some more surgical related risk factors? Well, there's been a meta-analysis performed that include over 30,000 cardiac surgical patients to assess for the risks of vasoplegia, and they identified several different factors. Now, specific to cardiac surgery, having an increased aortic cross-clamp time, an increased cardiopulmonary bypass time, as well as a combination surgery, so a CABG valve, all of those have increased the risk and odds ratio of having vasoplegia. And then one that they also found was renal failure and blood transfusions. And so we usually extrapolate a little bit of that evidence toward the general surgery and non-cardiac surgery population. But those are some of the surgical risk factors that put patients at risk for vasoplegia. So again, in cardiac surgery, the theory is that it may specifically be related to the cardiopulmonary bypass machine, as on-pump CABGs saw about 7% incidence, while off-pump was 3%, so almost cut in half. Other types of surgery, so transplant surgeries, heart, liver, kidney surgery, and then trauma and burn surgery. So what about drugs that patients are taking, home medications that patients may be coming and presenting to the operating room with? So ACE inhibitors and ARBs have always been in the spotlight, especially recently. And there's been some back and forth in the literature whether there's really a direct correlation between a patient taking their preoperative ACE or ARB and intraoperative hypotension. And so there is a potential association with intraoperative vasoplegia, but more research is definitely needed in this area. There has been some research saying that there might be a potential benefit in preoperative cessation up to 24 hours prior to surgery for both the ACE and the ARB. But again, there needs to be more investigation and more research needed to really be able to pinpoint ACE and ARBs as offenders in causing vasoplegia. Other drugs that have been implicated in vasoplegia are amiodarone, protamine administration, and metformin. So how do we treat a low blood pressure, which may then deteriorate into vasoplegic shock? With low blood pressure, we always start off with our standard treatment options. So phenylephrine, norepinephrine, epinephrine, and then potentially adjusting our anesthetic. And so these are some of the treatment options we use for hypotension and potentially for early onset of vasoplegia. However, once you've exhausted these standard treatment options, we need to go to what's termed as rescue treatment options. And so how do we rescue our patient and rescue our own anxiety with dealing with intraoperative vasoplegia? Well, there's a couple of drugs that have been under investigation and anecdotally used in case series and case reports, and we'll go through some of those today. So the most common one that you've likely heard of is Vasopressin and its close cousin, Terlipressin, Methylene Blue, Hydroxocobalamin, Angiotensin 2, and vitamin C. And so we'll walk through each of these treatment options. How do we administer them? What are some side effects? And how do we use these in our algorithm for treating vasoplegia? So to start off with, vasopressin, relatively common. Arginine vasopressin, or ADH, antidiuretic hormone, works on two fronts. It increases your systemic vascular resistance and it increases your blood volume, both of these increasing your arterial pressure. It binds to the arginine vasopressor receptor 1A, and it increases contraction of smooth muscles. The dosing, anywhere between 1 to 2 units of an IV bolus, followed by 0.02 up to 0.1 units per minute for an infusion. And now some of the side effects for vasopressin, which we may be familiar with, but as a good reminder, decreasing in platelet count, decreasing in renal blood flow, hyponatremia, the one that a lot of us worry about, the splanchnic vasoconstriction. And then if you're administering this through a peripheral IV, ischemic skin necrosis if infiltrated. And so we try to avoid administering this through a peripheral IV and really try to administer this and all of the drugs we'll be discussing today through a central IV. So the next drug is Terlipressin, which is, again, sort of related to Vasopressin. It's not currently FDA approved in the United States, but it is used in Europe. It's a synthetic prodrug analog of Vasopressin. It's more selective for that AVPR1A receptor. It helps decrease the production of nitric oxide. And the dosing is around a 1 milligram IV bolus dose with a 1 to 2 mics per kilo per hour infusion. And now some of the contraindications or side effects that you should look out for if you are administering this drug: patients with severe asthma, a history of cerebral vascular disease, as well as patients who may be pregnant. It is cautioned to use Terlipressin in those patients. So moving on, what's something that we don't normally think about for blood pressure outside of Vasopressin? Well, methylene blue. Methylene blue, or also the name brand Blue, it's a nitric oxide synthase inhibitor. It works on the vascular smooth muscle cells. It also works on the guanylate cyclase inhibitor, so it minimizes the cyclic GMP-dependent effect of nitric oxide. The dosing here is 2 mg per kg bolus of around 10 minutes, followed by an infusion of 0.5 mg per kg per hour. Now, this methylene blue usually comes in a 5 mg per ml vial. The effect of the bolus can be within usually around 15 minutes. And the peak effect for the bolus, and if you combine that with the infusion, will be around 1 hour. And generally in clinical practice, after giving the bolus, if you see a positive effect of the methylene blue, we generally start an infusion shortly after. If you give a bolus and you don't see any effect in the patient's blood pressure, we generally wouldn't start an infusion, because if they're not responding at all to the bolus, they're likely not going to respond to the infusion. And again, this particular aspect of vasoplegia that methylene blue works on is the nitric oxide synthase inhibitor. And so it works on that very specific part or component of what we think causes vasoplegic shock. At our own institution, we reviewed retrospectively around 45 patients who received methylene blue who were on ECMO, who were on VA ECMO. And so these patients already are high risk for encountering vasoplegia. And these 45 patients were diagnosed with vasoplegic shock, meaning that they were flowing as much as they could on the VA ECMO circuit, but they were still having low blood pressure despite high dose vasopressors and adequate volume resuscitation. And of those 45 patients, we had a 55 to 56% responder rate, positive responder rate, which means a greater than 10% increase in their MAP, as well as a reduction in norepinephrine dosing. We noticed here the blue line tracing out the responders and the green dotted line tracing out the non-responders. And you can see for the time since methylene blue administration, that at about 1 hour, you saw that peak effect of the blood pressure increasing. For the responders, almost as high as 77, 78 millimeters of mercury for their blood pressure. It then leveled out, but it always stayed above 65. Whereas the non-responders, unfortunately, did not have that much of a robust effect. They may have had a slight increase in their blood pressure, but did not sustain. And so that's why methylene blue really isn't the magic bullet for vasoplegia, but there's a subset of patients who do positively respond to the methylene blue. So we also noticed that if you didn't have at least a 5% increase in your MAP, the mortality, unfortunately, was 100%. So what are some warnings or some side effects, cautions for methylene blue? So you can have a temporary low pulse oximetry reading. Patients who have G6PD deficiency, you need to be cautious about giving methylene blue because it can cause hemolysis in these patients. And this may sound like a relatively uncommon deficiency, but in actuality, G6PD deficiency is the most common enzymatic defect. It occurs in about 5% of the population. And then serotonin syndrome is one that we have to be looking out for whenever administering methylene blue, especially with patients who are on an MAOI or SSRI or SNRI, linezolid and trazodone as well. So these three drug classes mixed with methylene blue can cause a serotonin syndrome. And then lastly, an increase in your pulmonary vascular resistance. So you have to be very cautious with patients who have severe pulmonary hypertension because it increases the vascular tone of all the vessels. And so that includes your pulmonary vasculature. So next up is hydroxocobalamin. Hydroxocobalamin comes in a formulary known as a cyanokit. It's a highly bioavailable form of vitamin B12. It's mainly FDA approved for cyanide toxicity, which is why it comes in this quote unquote cyanokit. It works several different ways. So it's a direct inhibitor of nitric oxide and nitric oxide synthase. It also binds sulfide and increases elimination of hydrogen sulfide. This hydrogen sulfide acts as an endogenous vasodilator. So you can understand how hydroxocobalamin can improve vasoplegic shock on two fronts, both the nitric oxide as well as the hydrogen sulfide. This drug has been used and reported in the literature for liver transplants, cardiac surgery, as well as in the ICU. And so the only downside, or one of the few downsides with this drug, as you can imagine, is the expense. And we'll go into a little bit more some details of what constitutes that expense. So the dosing is about 5 grams infused over 15 minutes. You may repeat this once, and the 5 grams is how much comes in that one cyanokit. For reference, the cost of methylene blue, the Prove Blue vial, is about $100. The cost of the hydroxocobalamin is about $1,200. And generally, for most OR pharmacies, they don't keep this on stock. It's mainly kept either in the emergency department for cyanide poisoning or in the main central pharmacy. Now, every institution is different, but because it's so expensive and the FDA approval is very limited in its scope with the cyanide toxicity, cyanide poisoning, it's very tough to get a hold of, and it's name brand. So this all adds into the cost and availability issue. The evidence for it, not a lot of RCTs, not a lot of strong evidence. A lot of the evidence that we have for hydroxocobalamin comes from case reports and case series. As you can see here in this graph, this is from a publication by Shaw et al. Based on 33 cardiac surgical patients. 24% of these patients had a favorable response at 20 minutes. As you can see here, group 2 in this graph had a very great and robust response up till about 20 minutes. And then after that started to level off and faded at about 60 minutes. And again, you had a responder and non-responder group, meaning this wasn't necessarily the magic bullet either. You had about 24% favorable response to the hydroxocobalamin. In another examination of hydroxocobalamin, patients received hydroxocobalamin. 3 patients received hydroxocobalamin, and they compared 30 minutes before and 30 minutes after hydroxocobalamin administration. As you can see here, there was a pretty robust mean difference in the MAP, almost an increase of 9 MAP points after hydroxocobalamin, with a reduction in your vasopressor doses. So what are some of the warnings and caution side effects of hydroxocobalamin? Well, one of the big ones is interference with dialysis equipment. And you can imagine if this patient is sick enough to require hydroxocobalamin, they may be encountering other organ dysfunction and potentially renal failure and renal dysfunction. And if they have to get dialysis, the hydroxocobalamin may not be your best bet here because it does interfere with the dialysis equipment due to the light absorption, light issues that can occur. That same theme with the light absorption and light changes is that it disrupts certain laboratory values that uses light to calculate these laboratory values like creatinine, PTT, PT, and hemoglobin. For the hemoglobin in particular, up to 12 to 16 hours of falsely elevated hemoglobin can be seen. For the PTT and PT, you can have up to 2 days of unpredictability, so high or low. And so it really makes you think twice before just administering this, especially in a patient who you're encountering in the operating room and who may have an extended ICU stay. And if these laboratory values are going to be perturbed for 12, 16 hours, or even up to 2 days, you may want to think twice. The other thing is chromaturia, red or orange urine, up to 6 weeks, but that's not really that clinically significant, but it is something to look out for. If you notice that in the operating room or when giving handoff in the PACU or ICU, you might notice this for up to 6 weeks. The only true absolute contraindication is hypersensitivity to hydroxocobalamin. Next up is angiotensin II. It goes by the name brand of Giapreza. It's a synthetic human angiotensin II. It restores the angiotensin II levels of the critically ill patient. It acts directly on the vessel wall to cause vasoconstriction, and it has catecholamine-sparing effects that have been noticed within 1 hour. The dosing is 20 nanograms per kg per minute infusion, and then you can titrate that infusion to up to 80 within the first 3 hours. The hydrogen sulfide release, which can lead to the inhibition of endothelial ACE activity, so that component of vasoplegia, the hydrogen sulfide release, then has a cascading effect. And so that endothelial ACE activity is reduced and inhibited. And so having this angiotensin II, the synthetic analog angiotensin II, can help increase your blood pressure. As a point of emphasis, when titrating, starting at 20 and titrating up to 80, you want to titrate every 5 minutes by increments of 10 nanograms. And so you want to be careful not to up titrate and get kind of a hyper reaction to the blood pressure. So where does a lot of the evidence for angiotensin II come from? Well, it comes from this large trial called the ATHOS-3 trial, or angiotensin II for the treatment of high output shock. They noticed that they had an increase of MAP within 3 hours of administration when compared to a placebo, and that was statistically significant with a p-value less than 0.001. Now, all of these patients were critically ill patients in the ICU, mostly suffering from septic shock causing vasoplegia. And their increase in MAP definition was an increase in MAP more than 10 points, or if it was above 75. The norepinephrine equivalent dose also decreased and was reduced within 3 hours. And as you can see here in this graph, within that first 3 hours, you had a pretty robust reaction to the angiotensin II with the MAP increasing, but then kind of leveling off after 3 to 4 hours. So a common theme with a lot of these medications is that it will help buy you time to increase the blood pressure while you try to at least address the underlying cause or help get the patient through the first couple of hours of this vasoplegic shock. Unfortunately, even in this ATHOS-3 trial, there was no change in 7 or 28-day mortality. So what about in cardiac surgery? So angiotensin II has been studied in cardiac surgery as well. As you can see here, angiotensin II compared to a placebo did have an increase in the MAP initially over the first 3 hours, but just like the ATHOS-3 trial, after about 3 hours, that positive benefit of angiotensin II as compared to placebo started to wane. They also had a reduction in norepinephrine equivalents. So it's not just increasing your blood pressure, it's being able to cut back and reduce the number of norepinephrine equivalents that you have the patient on. So what are some warnings specific to angiotensin II? So although there are no dose adjustments for renal and hepatic impairment, there have been noted events of thrombotic events, so arterial and venous thrombi. Mainly venous thrombi, and this again comes from that ATHOS-3 trial, but if this is a critical event for you, and in particular vascular surgery or cardiac surgery where you may be on bypass or partial bypass, encountering arterial and venous thrombi is very undesired. And so angiotensin II may not be the best drug during that bypass run. You can also have thrombocytopenia, hyperglycemia. And then one of the biggest drawbacks of angiotensin II currently is the cost. So it's $1,500 per vial. It is still name brand with the Giapreza. And so this is a relatively expensive therapeutic option. So what are some other options? So lastly, we have what's called HAT therapy. And so this is a combination of 3 drugs. Hydrocortisone, a 50 to 100 milligram bolus, followed by 50 milligrams every 6 hours. Ascorbic acid, or vitamin C, and then thiamine. Thiamine, 200 milligrams every 12 hours, infused over 30 minutes. And so this quote-unquote HAT therapy is actually under investigation currently, with a completion of around October 2021 of this trial to see if this combination of drugs can improve vasoplegic shock. More specifically, one that we may not think of is that vitamin C component. So we may be familiar with the hydrocortisone, we may be familiar with the thiamine, but the vitamin C may not be one that comes to mind when thinking of vasoplegic shock. And so there's preliminary evidence that this may work even outside of the HAT therapy. So it's relatively cheap. It's vitamin C. Any deficiency in vitamin C can cause hypotension. So the thought is that replacing the vitamin C, aiding in the synthesis of vasopressors, may help the vasoplegic shock. It increases the receptor sensitivity to catecholamines, both the endogenous and the exogenous catecholamines that you're administering. And the dosing is 1.5 grams IV every 6 hours. So a relatively high dose, but given every 6 hours. The one thing to also have some caution here is that there is some preliminary evidence that patients, again, with G6PD deficiency in concurrence with vitamin C administration can lead to hemolysis. Vitamin C outside of that can also lead to decreased platelet activation. But it's all a risk-benefit analysis, especially if your patient is profoundly vasoplegic and on very high dose pressors. So where does all of our evidence come from with vitamin C? Well, a lot of it comes from, again, case series and case reports. And so there was a case series of cardiac surgical patients, as seen here, where they were given vitamin C, and at 6 hours, as you can see here by the dotted line, we had a reduction in norepinephrine equivalent doses. And so on the x-axis is the time since administration, and on the y-axis is the norepinephrine equivalents. And so you can see at 6 hours, we did have a reduction. There was a reduction in norepinephrine equivalents. And then at around 12 hours, when that second dose of vitamin C was going in, you also had another reduction. In 2 of the cases, you had complete liberation of norepinephrine, and that was achieved within 24 hours. And now the norepinephrine equivalents that you see here on this graph were for vasopressin and epinephrine, meaning that their vasoplegia resolved, but they were still encountering potentially cardiogenic shock at that point. One of the other, as we discussed, was decrease in platelet activation and patients with G6PD. But one of the other things to consider is that it's relatively wasteful. The bottle of ascorbic acid is about 25 grams. And if all you need is 1.5 grams, that's about 3 mLs from that vial. And so it can, if you're not able to use that vial again, and in the operating room, you may only be giving 1 dose. It's relatively wasteful. Having said that, it is one of the cheapest of all the options we've discussed today. So to wrap up, let's walk through a little bit of an algorithm that we have when we encounter vasoplegia in the operating room. So the first is diagnosing that vasoplegia. So again, the cardiac index is greater than 2.2. We have a MAP less than 60, an SVR less than 800, and we have greater than 0.2 to 0.5 mics per kilo per minute of norepinephrine equivalents. Next, we want to make sure that we're adequately volume resuscitated. So we want to adjust the intravascular volume. We want to consider transfusing if the hemoglobin is less than 9. We want to optimize our volume status with crystalloid if we can. If all of that fails, we can turn to some other things. So we can adjust the anesthetic. We adjust to a TiVo rather than inhaled. We can rule out anaphylactic reactions or inadvertent drug administrations. We can address potential adrenal insufficiency with the hydrocortisone. And so we do all of these things before we come to the final diagnosis of vasoplegic shock. And so we continue with our conventional vasotherapy vasopressins. So we have vasopressin, epinephrine, norepinephrine, and phenylephrine. If we're exceeding our 0.5 mics per kilo per minute equivalent, then we can turn to our off-label or rescue agents. So the first off-label or rescue agent, as long as the patient doesn't have G6PD deficiency or is taking an SSRI or SNRI, usually is methylene blue. And part of this goes to the cost and ease of use and administration and familiarity. Secondly, we can move to hydroxocobalamin, and there has been some preliminary data to show that if you combine both the methylene blue and the hydroxocobalamin together, you could potentially, affect both the nitric oxide and the hydrogen sulfide components of vasoplegia, and that can help with vasoplegic shock. If that still doesn't work, and the patient doesn't have a history or is relatively low risk, all things considered, of venous thromboembolus, then you can consider angiotensin 2. Remembering that angiotensin 2 is relatively expensive, and so that's why it's third in our differential. And then lastly, if you've kind of thrown the entire kitchen sink, is HAT therapy. So making sure you're giving the hydrocortisone, the thiamine, and then the ascorbic acid. I thank you for your time and your attention, and I welcome any questions. Thank you.